Okay, good morning, everybody. Thank you for the invitation of coming here and giving my perspective of this quite interesting field. My name is Per Wester, and I'm a stroke physician working in Umeå, Sweden, as well as Karolinska Institutet Danderyd. And I will give you some insights into the prevention of thromboembolic events in AF. Again, my disclosure, I work for the Swedish National Board of Health and Welfare, writing guidelines. I'm a part of Rikstroke, the National Quality Register, and I'm involved in studies performed by St. Jude Medical. And I will start when you are awake this morning with the conclusion so that you don't fall asleep. So this is my last slide, and it's my first one as well. So I will come to the conclusion that cardioembolic stroke due to atrial fibrillation is common, stroke risk recurrence is high, secondary prevention effective with anticoagulants, NOACs or warfarin, but not aspirin, clopidogrel. And there is a gradual increased prescription of warfarin NOACs after cardioembolic stroke in Sweden. The incidence of intracerebral hemorrhages all over, that is quite constant over time, but there's a higher proportion of ICH patients that are on anticoagulants when they get their ICH. After an ICH and atrial fibrillation, the risk of ischemic stroke or death is substantial, and the best secondary prevention after ICH and atrial fibrillation is not at all clear. No treatment, antiplatelets, reinstall anticoagulants, warfarin, NOACs, or LAAO closure. I would like to start with a clinical case, a 71-year-old woman with hypertension, and that comes to my stroke unit with mild, moderate right hemiparesis. ECG at the acute department shows sinus rhythm. CT brain and CT angio unremarkable. Preliminary diagnosis, ischemic stroke. Started with aspirin, low dose. 48-hour Holter ECG shows intermittent AF. And with this ECG, we've got the diagnosis of cardioembolic brain infarction. And this cardioembolic infarction that is due to with atrial fibrillation is the dominating cause. And of course, this is for you all very, very known, but embolus from the left atrial appendage to the brain, and 7 out of 10 clots from this part of the heart will end up in the middle cerebral artery of the brain because of the cardiac output is so large. 20 to 25% of the blood from the heart goes to the brain, and the anatomy of the brain vessels that it goes off from the aortic arch so early. How about screening to find this atrial fibrillation, this proximal atrial fibrillation after ischemia, after ischemic stroke or TIA? And then quite often telemetry is done for a day or two, Holter ECG 1 to 7 days, thumb ECG or smartphone ECGs, 30 seconds times 2 to 3 times 14 to 28 days. And then there are chest patch, the Zio patch, for example, and then there are also other out in the market, as well as you could do implantable subcutaneous detectors for up to 3 years. And when you do this screening, the general rule is that the longer you screen a patient that has got the sinus rhythm when coming to at the emergency department and stroke unit at first, when you start screening, and the longer time you screen, the more yield you get. And this is a meta-analysis recently published that shows that newly diagnosed atrial fibrillation in 1 out of 8 patients, 13%. But with longer registration, you find even more than that. So how about our 70-year-old lady? What is her risk for recurrent stroke and bleeding risk? And the general risk Stratification we're using, that is the Schädl-Svask score, and she will get a 5 point on that. And the HAS-BLED, that is mostly used. It's not so very much used in the clinical arena, but if one is using a bleeding score, that is the HAS-BLED that is quite by far most used. And 4 points she will get on this HAS-BLED score. The risk then, what is the risk if we leave this patient without any anticoagulants at all? And this is one example out of many that shows with the Schädl-Svask of 5, she's got a substantial risk of getting a stroke or systemic embolism here. So that means with a quite high risk of recurrent ischemic stroke or systemic embolism, and a high risk of, in the HAS-BLED score, different secondary prevention option in this cardioembolic stroke is not aspirin, and aspirin plus clopidogrel could be used in certain very few cases, but it's anticoagulants, warfarin or NOACs, and with dabigatran, rivaroxaban or apixaban, and I will not go into those in detail here, but they are in guidelines, they are considered to be equal. This is from the Rikstroke register that covers most of the patients in Sweden with stroke TIA. And this is over time, the percentage of TIA percentage with atrial fibrillation and that are prescribed anticoagulants at discharge. And as you could see, there's increased frequency of anticoagulants that are used. But then it is the majority still in 2014, that was warfarin and not the NOACs. We'll have preliminary results for 2015, and it's happening quite fast. But with the NOAC studies in atrial fibrillation and guidelines and so forth, it's a bit of, it takes time, but I would guess that these proportions would perhaps be the opposite in quite soon here. So this is for the TIA patients. How does it look for the ischemic stroke patients? And here we could see over a little bit longer time that patients below 80 years of age, that here we treat in Sweden 3 out of 4 patients. And elderly patients over 80 years, then that is also 50 to 59. And now there's there used to be quite big of a gender difference here, but that is quite small now. We come back to our stroke patient, and she was prescribed warfarin, INR 2 to 3, first uncomplicated, but after 14 months she gets a new stroke recurrence, this time with a lobar intracerebral hemorrhage, volume 15 milliliters. She's treating in a non-intensive care at the stroke unit, apart from, and we treated with aggressive antihypertensive treatment according to INTERACT-2 study trial. And she makes a remarkable recovery that she should do with such a small hemorrhage. We could look at the number of ICH patients over time. So this is from 2008 up to 2014. And what we could see, and Rikstroke is covering it covers the most of all stroke patients, including ICH patients. So we don't miss many. And you could see that it's quite stable. The number of ICH cases does not seem to increase over time. But then the proportion of the ICH patients that are on oral anticoagulants at the time when they get their ICH, that is increasing. How about the risk of getting something new in our stroke patient? And this is from a Danish study that shows a substantial early risk of ischemic events, stroke, systemic embolism, and TIAs. And the risk is especially high in the early phase here. If we look at the different events in non-ischemic, non-ICH, that is ischemic stroke, and the ICH, you could see that the mortality is so much higher in the ICH patient compared with the ischemic patients. The event ratio for major bleedings, that is quite similar. But then the event rate for stroke, embolism, and TIA, that is much higher in this ICH group compared with the non-ICH. So what choice of antithrombotic treatment should we have now? In this patient that used to have an ischemic embolic stroke, treated with warfarin, coming again with an ICH, and she's recovering from that. And again, a little bit how it looks like. And this is retrospective data, and this from long-term clinical practice from, this is over time, 2005 to 2012. These patients, we stroke physicians, we don't know how to treat. And so about 40% in Sweden, they were not treated at all. Too scared of putting them on anything at all. 21% on anticoagulants and 40% on antiplatelets. And when looking at the correlation of prescription of anticoagulants with risk of stroke or bleeding, the SHADS-VASc score has bled. There's no correlation at all. If it's a correlation, then the SHADS-VASc, lower SHADS-VASc scores seems to be associated with a higher prescription rate here. So we don't use those SHADS-VASc and has bled scores at all in those patients. How about risk of ICH to have a new intracerebral bleeding in this patient? And this is perhaps that some of you have been participating in this Italian observational study, the Chiron study, that shows that an extremely high risk of recurrent ICH in this observational study of 267 patients. Out of 45% were spontaneous intracerebral hemorrhages. Another retrospective German cohort study, 19 German tertiary care centers, 2006 to 2012, with 719 cases analysis of oral anticoagulation resumption. And these are retrospective data, and that are hypothesis generating. But ischemic events, patients with oral anticoagulants seem to do better when compared with no oral anticoagulants concerning ischemic events. No major changes, but perhaps a bit more of hemorrhagic events. And the survival rates were also different. But note that this is a retrospective register study. And then a Danish nationwide cohort study of intracranial bleeding with atrial fibrillation, that is subdural hematoma and subacrinoidal hemorrhage that also were included in those. And here also indicates there might be some benefit of resumption with OAC compared with antiplatelets or none. But it's, again, this is a register study and hypothesis generating study. So I'm coming back to my conclusion slide. So I'll repeat it again if you forgot what I said in the beginning of my talk. So cardiembolic stroke TIA due to atrial fibrillation is quite common. The stroke risk is high, secondary prevention effective with anticoagulants, NOACs or warfarin, but not aspirin, clopidogrel. And there's a gradually increased prescription of warfarin, NOACs after cardiembolic stroke in Sweden. The incidence of intracerebral hemorrhages is unaltered over time, but a high proportion of ICH patients are on anticoagulants. After ICH and atrial fibrillation, the risk of ischemic stroke and ischemic events or death is substantial. Best secondary prevention after ICH and atrial fibrillation is not at all clear. No treatment, antiplatelets, reinstall anticoagulants, warfarin or NOACs, or to do LAAO closure. Thanks.